Hello everyone, today we're going to talk about positioning for the toes, the foot, and the ankle. So as far as patient preparation is concerned, you want to make sure that you remove any artifacts from the anatomy of interest. Of course, if you're doing the foot, you want to remove the shoe. Also any socks, any kind of hose of any kind of elastic causes artifacts. And you also want to make sure that any heavy fabric is rolled above the anatomy of interest. For example, if they've got jeans on, you want to make sure if you're doing an ankle that you roll up the pant leg well above the area that you're radiographing. As far as general patient position, as far as ambulatory patients are concerned, seated on the x-ray table or they can be lying down. Affected limb rests on the IR. It's placed on the tabletop. We don't do toe, foot, or ankle in the bucky. It's going to be tabletop. For non-ambulatory patients, you're going to alter your positioning to maximize your patient comfort. And you're going to transfer from the stretcher to the table only if the patient was able to do that themselves. If they can't move, you can just go ahead and do it right on the cart. Might be a little bit easier doing it on the cart rather than moving the patient to the table. As far as the IR or collimated field size, the textbook Merrill's gives you guidelines for that. I want you to make sure that you look at those guidelines as far as collimation is concerned. As far as if you're going to place more than one projection on an IR, you've got to make sure that you use a lead strip to protect the unexposed side of the IR. With digital imaging today and our detectors, generally you're just doing one-on-one. SID is 40 inches as the standardized SID for toes, foot, and ankle. As far as ID markers are concerned, we're going to use a right or a left. If you're going to split your cassette and one side you're going to cover with lead, the other, you don't have to put the marker on each exposure on that single cassette, but it has to be at least on one of the projections. Remember, we want to use our lead markers whenever possible. We want to try and avoid digital annotation. And also we have to make sure that other required ID markers are in the blocker or elsewhere on the final image. As far as radiation protection is concerned, we want to shield our pediatric patients and patients of reproductive age. There are guidelines for you in Merrill's on pages 33 to 34. Other radiation protection measures, we want close collimation. We want to use optimum technique factor. So these are out of Merrill's. So 63 at 2 for CR. Remember, DR, we can pretty much cut the technique in half, so 0.9. For a foot, 70 at 2.5 or 1.25 DR. Ankle, 70 at 3.2 or 1.8 DR. And for the lateral of the ankle, 70 at 2.2 or 1.25 mass for DR. Patient instruction, we want to make sure we explain what we're doing to the patient. We may have to demonstrate a position. Breathing instructions are not required for any distal lower limb procedures. You're basically just telling the patient to hold still. As far as essential projections are concerned, for toes, we do an AP or an AP axial. We do an AP oblique, and we do a lateral, and depending on the toe, it's either going to be a medial lateral, or a lateral medial lateral. All of the toes are going to use the same collimated field size, 1 inch on all sides of the toes, including 1 inch proximal to the MTP joint. So make sure that you open that collimation to include at least 1 inch proximal to the metatarsal phalangeal joint. For AP or AP axial toes, AP axial is recommended to open up joint spaces and reduce foreshortening. You may be at a site, however, that they don't angle and it's just a straight AP. As far as part positioning is concerned, once again, the patient can be seated on the table or lying down. You want to make sure that you flex their knee with the sole of the foot resting on the IR. The toes are centered to the unmasked portion of the IR. May be elevated on a 15-degree wedge sponge for the axial, or you can angle your central ray 15 degrees. So we want to keep in mind the angulation for toes is 15 degrees. 15 degrees. And then the long axis of the foot is aligned parallel. Central ray, as I said, could be, if it's just AP, it's straight down perpendicular, or if you do the axial, it's going to be 15 degrees posteriorly. Maybe perpendicular if toes are elevated on a 15-degree wedge sponge. So either a sponge to bring the toes up 15 degrees, or you can angle the central ray. And you're going to enter at the third MTP joint, opening up your collimation to include all of the toes. The AP oblique toes, medial rotation. Knee is flexed, leg and foot are medially rotated enough to place the plantar surface at a 30 to a 45 degree angle. So you got a little bit of a range there, 30 to 45 degrees from the plane of the IR. Center the toes to the unmasked portion of the IR, and central ray is going to be straight down perpendicular to the third MTP joint. For the laterals, you're going to do individual toes. So patient position the lateral recumbent on the unaffected side. Part position, lateral with gauze separating the toe of interest from the others. Tape the other toes inflection. Merrill says you can use gauze. I only basically use tape. Pull the toe out away from the other toes, tape that toe in position, and tape the other toes back. Central ray is perpendicular to the MTP joint of the great toe, and it's perpendicular to the proximal interphalangeal or PIP joint of the second toe. So for the great and the second toe, you're going to lay the patient on the unaffected side. So if you're doing the left big toe, you're going to lie them on the right side. For the third to the fifth toes, those toes, you're going to lay the person on the affected side. So if you're doing a left third toe, you're going to lay the patient on the left side. Part position is lateral, separated from other toes with immobilization, and central ray is directed once again perpendicular now to the PIP joint of the affected toe. Let's move on to the foot. For the foot, you also can do an AP or an AP axial. We do an AP oblique, and we do a lateral, which is going to be a medial lateral. Remember, medial lateral means that it's entering the medial side of the body, exiting the lateral side, and it's in a lateral position. For the AP or the AP axial foot, the axial projection demonstrates the tarso-metatarsal joint spaces better, also helps to reduce foreshortening. Part position, once again, patient can be sitting or lying down. The knee is flexed, and you're resting the plantar surface of the foot on the unmasked part of the IR if you're going to do 2-on-1. Leg is vertical. Long axis of the foot is aligned parallel. AP or AP axial foot continued. Central ray, AP is perpendicular to the base of the third metatarsal. So that's very important, base of third metatarsal. If you're doing the AP axial, you're going to angle 10 degrees toward the heel, once again to the same place, the base of the third metatarsal. So we want to keep in mind the differentiation in the angles for the AP axial of the toes versus the AP axial of the foot. AP axial toes is 15 degrees, AP axial foot is 10 degrees. And your collimated field is 1 inch on the sides and 1 inch beyond the calcaneus and distal tip of the toes. So we got to make sure we have the entire foot in the collimated field. For part positioning, for the AP oblique foot, it's going to be medial rotation. The knee is flexed if you look at the picture there. Very, very important. For the AP oblique of the foot, we do not rotate the foot 45 degrees. It is a 30-degree medial oblique. So plant that in your brain, AP oblique foot 30 degrees. We're going to align the long axis of the foot parallel, and the foot is going to be centered to the middle of the central ray. No angulation, it's perpendicular, and once again you're going to the base of the third metatarsal, keeping that collimated feel 1 inch on the sides, 1 inch beyond the calcaneus and the distal tip of the toes. Move on to the lateral of the foot. Once again, it is a medial, lateral, lateral. So we're going to enter the medial side of the foot. Patient is recumbent on the table. Turn toward the affected side. So if I'm doing a right foot, I'm going to rotate them so they're laying on their right side until the leg and the foot are in a true lateral. For part positioning, sounds a little bit strange because we're x-raying the foot, but we really want to look at the patella, the kneecap. We want to make sure that we elevate the knee so that knee comes off the table a little bit. Elevate the knee to place the patella perpendicular to the table. Once that patella or a plane passing through the patella is perpendicular, you're going to have a good lateral of the foot. We're going to center the foot to the IR. We're going to align the long axis of the foot parallel. And very importantly for a lateral of the foot, we want to dorsiflex. So we're going to dorsiflex the foot to 90 degrees from the leg. Central ray, same place, perpendicular to the base of the metatarsals. Okay, so it's not going to be to the third, obviously, because now you're from the side, but to the bases of the metatarsals themselves. Collimation remains 1 inch on the sides and on all sides of the shadow of the foot, and includes 1 inch proximal to the medial malleolus. You want to be very careful that you look at the shadows. Make sure that your shadows are not clipped out of the light field. You've got to make sure you open that light field enough to get the shadows of the individual toes and calcaneus. Special view sesamoid. We've got a tangential projection that we can do for the sesamoid. Basically what you're going to do if you're doing the Lewis method, you would have the patient lying prone. Look at the picture there. You're going to bend the toes forward, and then you're going to use a perpendicular tangential beam to the first MTP. If you're doing the patient supine, you're going to wrap a long strip of gauze or a sheet and pull the foot back. Central ray is going to be to the same place. You're using this tangential beam. And what you're going to get then are the little sesamoid bones being seen. You can see down at the bottom there in A. B is actually showing you a fracture of one of the sesamoid bones. So for sesamoids, tangential, prone is Lewis, supine is Holly method. In Merrill's, it talks a little bit about something called Talipes equinovarus, which is congenital clubfoot. These are x-rays you would do on an infant, generally, that would have clubfoot. As far as clubfoot is concerned, 3 deviations from the normal alignment of the foot in relation to the weight-bearing axis of the leg. When radiographing a baby with the condition, a primary objective is that no attempt be made to change the abnormal alignment of the foot when placing it on the IR. It's going to look like a very strange AP because if you look to the top of this slide and you look at the way the congenital clubfoot looks, okay, you're basically just going to set that foot on the cassette. You're not going to try and change the alignment. The names of the methods are kite and candle, and I would like you to view a video on club feet. The link is there, so when you're on Moodle, you can go ahead and click on that link to watch this video on club feet. Special projection for the calcaneus. Remember, calcaneus, also called the os calcis. We're going to do an axial, which is a planto-dorsal. We're going to enter the bottom of the foot, the plantar surface, and exit from the back. And we're going to do a lateral, which is a medial lateral lat. So basically what you're going to do is you're going to extend the patient's leg out, ankle in a right angle dorsiflexion. So you're going to pull that foot back. Generally, you wrap then some gauze or a sheet around the foot, pulling it back as much as the patient can tolerate without bringing the foot off of the cassette. The foot has to remain on the cassette, so don't have them pull so hard that the foot starts to rise off the cassette. Ankle is centered to the unmasked part of the eye. Very, very important angle for you to remember is 40 degrees. So when we do the calcaneus, we're going to do a 40-degree angle. Remember the hand, we did that special view for the scaphoid. That was 20 degrees for the Stecker method. In the foot, it's going to be that 40 degrees cephalic angulation into the calcaneus. And you're entering, once again, the plantar surface, the bottom of the foot, at the base of the third metatarsal. Base of third metatarsal again. Collimation 1 inch on 3 sides of the shadow of the calcaneus. For the lateral of the calcaneus, patient position resting on the affected side. So if I'm doing a right calcaneus, I'm going to lay them on the right side. Leg is almost lateral. Heart position, calcaneus is centered to the middle of your IR, and the long axis is aligned to the IR. Central ray, perpendicular to the calcaneus. How are you going to know where that's at? We're going to go 1 inch distal to the medium malleolus at basically the joint right under the talus, which is called the subtalar joint. So 1 inch distal to medium malleolus. Collimated field, you're going to adjust your collimator to 1 inch past the posterior and inferior shadow of the heel. So we don't want to clip any of the heel off. We want to include the medium malleolus and the base of the 5th metatarsal. Let's move on to the ankle. There are 3 basic projections for the ankle. The AP, the lateral, which is a mediolateral lateral, and the AP oblique, either for the ankle joint, which is the mortis joint, or for the ankle, the bony structures. We'll talk about that in just a couple of minutes. And stress views are sometimes done for the ankle as well. Let's talk about the AP of the ankle. So a patient is going to be lying on the table. The leg is extended. Ankle is centered to the unmasked part of the IR. The ankle then is flexed to place the long axis of the foot vertical. You want to make sure that the bottom of the foot is vertical. Central ray is perpendicular through the ankle to midway between the malleoli. So you look at the picture there, you can see where the malleoli would be. Look at the pointer indicating where the central ray would be. Collimated field is 1 inch on the sides of the ankle and 8 inches lengthwise to include the heel. So you want to have that length. You're not going just for the little joint space. You're going for that whole area. For the lateral of the ankle, patient would be turned toward the affected side. Place the leg and the ankle in a lateral position. Heart position, center the ankle to the unmasked part of the IR, and we're going to dorsiflex the foot to a right angle. So once again, dorsiflexion is very important here. Central ray is perpendicular to the ankle joint. You're basically going to be entering the medial malleolus. Collimation pretty much remains the same, 1 inch on the sides of the ankle, and once again, you're getting that 8 inches lengthwise. You want to make sure you're including the heel and the 5th metatarsal base. For the AP oblique ankle, the leg is extended. Ankle centered to unmasked part of IR. Foot is dorsiflexed to a right angle. And for the bony structures of the ankle, it's a 45-degree oblique. 45-degree oblique. Central ray is perpendicular to the ankle joint, midway between the malleoli again. Look at your collimated field, remaining the same, 1 inch on the sides, 8 inches lengthwise. Make sure you include the entire heel. Now we're going to talk a little bit about something called the AP oblique for the mortis joint. And this is what most sites do. Down at the bottom, you've got a radiograph there showing you the difference in the bony presentation of your AP versus the mortis view. So for the mortis or mortis, some people say mortis, the leg is extended, ankle is centered to the unmasked part of the IR. Foot is dorsiflex to a right angle. Leg and the foot are medially rotated, very important for the mortis or mortise view, 15 to 20 degrees. How are you going to know 15 to 20 degrees? Well, you're going to palpate the malleoli. Your lateral malleolus is a little bit more posterior in your body than is your medial malleolus. So you're going to rotate until the plane passing through the malleoli is parallel with the IR. You're going to see it doesn't take a lot of rotation to do that, only about 15 to 20 degrees. So the oblique for the mortis joint is 15 to 20 degrees. And this is what you probably are seeing most clinical sites doing. Central ray perpendicular to the ankle joint, you're going to enter midway between the malleoli. Collimation remains the same, 1 inch on the sides, 8 inches lengthwise. And then we've got a special view that is called a stress view of the ankle. So why do we do these? The stress is used to verify ligamentous tears. I'd like you to read about this a little bit more in your book. You're dealing with a possible tear here, and you're going to be applying force, or not you, but actually the doctor would be doing this. And they're going to numb up the area because this is, if there is a tear, it's going to be a lot of pain. So our part position is basically the same as an AP. The physician places the foot in extreme inversion and eversion position. So they're going to invert, they're going to evert, and you need to make sure that there's a mobilization for each exposure. That when the doctor turns, it's not moving the leg out of position. Some common fractures for the toes, foot, calcaneus, and ankle. We've got a pot fracture or Pott's fracture, which is an avulsion fracture of the medial malleolus with a loss of the ankle mortis. We also have a Jones fracture, which is an avulsion fracture, a pulled away fracture of the base of the fifth metatarsal. You can see very well, you can see this on the oblique of the foot. Let's take a look at some images and evaluate. So for AP or AP axial toes, here's what the radiograph should look like. Evidence of proper collimation, entire toes, including the distal ends of the metatarsals, are included. You want to make sure that the toes are separated from each other. Sometimes people do have toes that overlap one another, in which case you're going to have to try and separate them. You may have to tape them down. No rotation of the phalanges, soft tissue with and mid-shaft concavity are equal on both sides. It's a straight AP. You should see concavity on the phalanges on both sides. Open IP and MTP joint spaces on the axial projections, soft tissue and bony trabecular detail should be seen. For the oblique of the toes, notice how you can tell, look at those sesamoid bones, they've shifted over now. Evidence of proper collimation, entire toes, including distal ends of metatarsals. Toes are separated from each other. Proper rotation of toes is demonstrated by more soft tissue width and more mid-shaft concavity on the elevated side. Open IP and second through fifth MTP joint spaces. First MTP joint isn't always open, and you want to see soft tissue and bony trabecular detail. For the lateral of the toe, when you look at the radiograph, you can see that the toe is pulled away, the toe of interest is pulled away from the rest of the toes. So we want to have evidence of proper collimation, the entire toe without superimposition of adjacent toes. When superimposition cannot be avoided, the proximal phalanx has to be shown. Toes are in a true lateral position if the toenail is in profile. Sometimes you see it, sometimes you don't. If you do see it, it should be in profile. Concave plantar surfaces of the phalanges. No rotation of the phalanges. Open interphalangeal joint spaces. The MTP joints are overlap but may be seen in some patients. And we should see soft tissue and bony trabecular detail. For the AP or AP axial of the foot, notice you're not going to, on an AP foot, see calcaneus very well because it's going to be covered up by the leg. but certainly the phalanges, the metatarsals, and the anterior tarsal bone should definitely be seen. So evidence of proper collimation, anatomy from toes to tarsals may include portions of the talus and calcaneus. No rotation of the foot as demonstrated by equal amounts of space between the second through the fourth metatarsals. And I want you to look at the bases of the metatarsals. Overlap of the second through the fifth metatarsal bases. So notice your first metatarsal base is not superimposed by the other bones, but when you look at the bases of the second through the fifth metatarsal, you are going to have overlap. Axial projection results in improved demonstration of the IP, MTP, and TMT joint spaces. So remember, when we angle, we open up joint spaces better. Open joint space between the medial and the intermediate cuneiforms, and soft tissue and bony trabecular detail should be seen. For the AP oblique of the foot. So when you look at this, I want you to make sure that you notice a couple of things. Notice how you pull the base of the fifth metatarsal out. Also, you have this hole, almost looks like a little hole, a black hole in the middle of the tarsal region, which is called the sinus tarsi. You're going to demonstrate the sinus tarsi very well if you don't over oblique. Remember, the oblique of the foot is how many degrees? That's right, 30 degrees. 30 degrees for a medial oblique of the foot. So if we look at the criteria, evidence of proper collimation, entire foot from toes to the heel, proper rotation of foot, third through fifth metacarpals are free of superimposition. So look at those metacarpals free of superimposition. The bases of the first and second metatarsals are superimposed on the medial and intermediate cuneiforms. Navicular, lateral cuneiform, and the cuboid with less superimposition than in the AP projection. Lateral TMT and intertarsal spaces, joint spaces are seen. Sinus tuberosity of the fifth metatarsal, so that base of the fifth metatarsal. The sinus tarsi should be seen, that little hole, and soft tissue and bony trabeculation. The other thing that I want you to note on the AP oblique of the foot is take a look at that cuboid bone. And notice on a well-positioned oblique of the foot, you can demonstrate, or you demonstrate, all of these spaces around the cuboid bone. For a lateral of the foot, evidence of proper collimation. The entire foot and distal leg are seen, so you don't want to clip off those malleoli. Superimposed plantar surfaces of the metatarsal heads, fibula overlapping the posterior portion of the tibia. The tibio-talar joint should be seen, and soft tissue and bony trabecular detail. Let's move on to the calcaneus. Here's the axial calcaneus. So you should see evidence of proper collimation. You should see the calcaneus and the subtalar joint. So look at those joint spaces. No rotation of the calcaneus, the first or fifth metatarsals not projected to the sides of the foot. Anterior portion of the calcaneus with brightness similar to the posterior portion. 2 images may be needed for the 2 regions of thickness. So when you do this today with digital imaging, you generally don't have to take 2 images. Oftentimes when film was used, you did because you'd end up burning out one part or the other, or one part would be too light compared to the other. You wouldn't see the joint space, for example. But today with digital imaging, we can do our window leveling and our window width adjustments, and we can pretty much see what we need to, or the radiologist can see what he or she needs to. Soft tissue and bony trabecular detail should also be demonstrated. For a lateral of the calcaneus, evidence of proper collimation, entire calcaneus including the ankle joint and adjacent tarsals. No rotation of the calcaneus, we're doing a lateral. Tuberosity is in profile. The sinus tarsi, you can see it again there, that little hole. For identification purposes, look in the book, it's labeled in Merrill's if you don't know where to look here. So the sinus tarsi should be open, and the calcaneocuboid and talonavicular joints are open, and soft tissue and bony trabecular detail are seen. For an AP of the ankle, take a look at the more rectangular collimation, which is what you want on an AP of the ankle. So evidence of proper collimation, the ankle joint is centered to the exposure area. You want to see the medial and the lateral malleoli. You want to see the talus with proper density. And it's an AP, so you don't want any rotation. So normal overlapping of the tibiofibular articulation with the anterior tubercle slightly superimposed over the fibula. Talus slightly overlapping the distal fibula. No overlapping of the medial talomalleolar articulation. The tibio-talar joint space is seen, and soft tissue and bony trabecular detail are seen. For the lateral of the ankle, proper collimation. Ankle joint is centered to the exposure area. Distal tibia and fibula, the talus, all of the calcaneus, and the adjacent tarsals should be seen. Ankle in true lateral position when the tibio-talar joint is well visualized with the medial and lateral talar domes being superimposed, two sides of the dome of the talus. Fibula over the posterior half of the tibia. So look at the fibula. Notice how it's superimposed over the posterior half of the tibia. Fifth metatarsal base and tuberosity should be seen to check for a Jones fracture, so don't clip that off. Brightness and contrast of the ankle sufficient to see the outline of the distal portion of the fibula, and soft tissue and bony trabeculation should be seen. Here we've got the AP oblique ankle. This is the 45-degree rotation, so proper collimation. Once again, that rectangular collimation. Ankle joint is centered to the exposure area. We want to see the distal tibia, fibula, and talus. Proper 45-degree rotation of the ankle. Tibiofibular articulation is open. Distal tibia and fibula overlap some of the talus. And you should see soft tissue and bony trabecular detail. For the Mortis or Mortis view, evidence of proper collimation. Entire ankle mortis joint centered to the exposure area. Distal tibia, fibula, and talus are seen. And that proper 15 to 20 degree rotation of the ankle will give you the following. A talofibular articulation being open. The tibio-talar articulation is open. No overlap of the anterior tubercle of the tibia and the superolateral portion of the talus with the fibula. And we want to see soft tissue and bony trabecular detail. So all the joint space around the talus.